Hello, everyone. My name is Lina Goran. I'm marketing manager in Alpha Biotech, and I'm happy to welcome you today at our webinar with Dr. Henriette Lerner. The webinar today will focus on discussing the algorithms and techniques of tissue management and full digital workflow, and I'm happy to introduce the speaker. Dr. Henriette Lerner. She is a past president and an honorary member of Digital Dentistry Society. She is a member of numerous professional societies, and also she is a speaker and lecturer at Frankfurt University, Germany. And Dr. Lerner is leading her dental practice in Baden-Baden, Germany, with a focus on implantology, aesthetic dentistry, and digital dentistry. So we're going to have today very interesting and deep webinar on aesthetics and digital dentistry. If you have questions, please write them on the chat, and the speaker will answer them by the end of the webinar. This session is going to be recorded. Dr. Lerner, please. Dr. Lerner, we don't hear you.
Can you hear me now?
Yes, we do.
Yes. Hi, how are you, Elena?
Good, good. How are you?
Oh, I want to say hi to everybody. I saw that there's almost 50 people from all around the world. I hope that everybody is healthy, and I'm glad that I can communicate with you on this virtual way and share with you some of the digital workflows and parameters which we encounter today. I will share my screen a little bit and then we move on. Yeah?
Okay, so let's start.
Okay. Can you hear? You don't? Just a second. Just 1 second. So now. So can you hear me again? Hello?
Yes, yes, we can hear you.
I have to thank Elena personally for her friendship and support from the side of the company. We are very many times in Baden-Baden together with the different groups from different countries. And I'm very pleased and very honored that she asked me to hold this webinar. Thank you so much, Elena, again.
Thank you very much, Henriette, for having this educational event for us. We're always pleased. Thank you.
It is a big pleasure also to hear that, as Elena told me, that I heard Romanian speaking, Bună ziua. I heard Hungarian speaking, Jó napot kívánok. I don't know all the languages where you're coming from, but I think we all speak the common language of implant dentistry, of aesthetics, of digital dentistry. And that is actually, those are the topics which I would like to touch with you today in a kind of around an hour. And for sure is it the case that you did as implant dentists a lot of cases, simple cases or complex cases in a so-called free-hand implant placement, because this is the procedure which we learned 30 years ago. And those are also the infrastructures, the implant infrastructures, which allow us to recreate the smile of the patient also in very compromised implant situations. In compromised bony and soft tissue situation, we managed to re-establish on dental implants, even if they were free-hand placed, pleasing or a solid support. And you will ask me in the chat for sure why we have so many implants. I will answer it at the end, right? And we try through this stable infrastructure to re-establish also implant by implant as much as possible aesthetic result or aesthetic picture. Concerning the procedure that we use on implants, we grew up with the immediate placement, immediate loading procedure in single teeth, but also in full arch reconstructions. And we were all happy when we had implants which have that self-cutting feature, that primary stability that they encounter in almost any bone quality, because those are the parameters which allow us to load immediately the implant and assure us a good stability of the constructions on the long run. And if you see the success rate of these full arch reconstructions in the last couple of years in my office, you can compare it with studies of Deborah Schwartz, Carl Misch, De Guidi, Piatelli, all these clinicians which are doing the same procedure, and actually all the world is doing now. And you see that the success rate of the implant placement in full arch reconstructions is high enough, not only in my statistics, but also in all the studies. But we don't want just to re-establish a denture on some implants, and that is why not necessarily we do only support for some dentures or for some edentulous situation. We would like to give the patient the perfect aesthetic, as well as on implants, as well as on natural teeth, even if we have adjacent implant situations, or even if we have adjacent implant and tooth situation. This is actually the target. And of course, there are possibilities and indications, and I will focus on those too, where you can do a bridge, and you may do a bridge with all those disadvantages on implants, or where is the advantage and where should we where should we target to a tooth by tooth reconstruction on implants when the patient is young, when the patient wants to behave and to have a natural similar situation. So all those parameters which we learned in the freehand implant placement, where we graft the rules of grafting of a defect, which we also do now, they are still the same. And if we talk digital and we walk and we work digital, we should be still the surgeon, and we should know even better than before all the rules of the bone grafting, of the soft tissue management and the soft tissue grafting. Also, the rules which we learned, and the ones which attended my course, learned the parallel rules of placing the implant, doing the bone grafting, doing the soft tissue management and the soft tissue grafting in the same session. So all these things are very, very important also in the digital workflow. The difference is that when we go digital and we don't necessarily want to open the flap, we have to have in the first row methods and techniques which makes and keep that treatment minimally invasive, and don't do a big flap if it's not necessary. If you go digital, use that advantage, and also to use methods which makes our treatment predictable. So when we do a grafting, we should know how much grafting we do, how much soft tissue grafting we do, with which materials, what do we use, which technique and which materials, in order to get to a result which is predictable. Because this is what we aim through all the implementation of the technologies in our workflows, in our clinics, a higher predictability. That is why we were fascinated by the static navigation, and in a second step, a dynamic navigation. And I would like to go with you through the workflows of those two new technologies step by step, with their advantages and disadvantages on hand of clinical cases, more recent one, and also older ones, which we used in studies, and also to offer you parameters which you can use in the daily office and in your digital workflow. So the question is, since digital dentistry is a quite newcomer in dentistry, but nevertheless is the dentistry which we practice more and more today, and we will practice in the future only. This is the contemporary dentistry. We need to know, where are we now on those technologies, how reliable they are, where is the accuracy, precision, and trueness of those devices that we use today, and what kind of parameters should we use, what is well known, what we still need to encounter on, or to implement, or to improve in the future in the digital workflow, in order to have a higher, even a higher accuracy, trueness, precision, even a higher predictability, and last but not least, a better aesthetic success. So we pretend, and we hope in the same time, that digital dentistry offers us a more minimally invasive procedure, that it gives us a higher precision. We will see, that is offering us a better aesthetic, a better functional outcome, that it has a higher predictability in many terms, and it's a reduced time of treatment. So let's see if it's like that or not. So the way I did my statistic on the freehand cases, that way we did together with Professor Sada and Professor Ganati and our colleague from the DDS board, Uli Hauschild, who is the technician who is doing most of the cases, not all of them, but a couple of the cases that you will see. We made a retrospective study on these cases in a full arch reconstruction, immediate loading, immediate implant placement, and immediate loading. And we realized that we have even a higher success rate than before. The static navigation is a navigation in implant dentistry which is guided by a static device. And it can be split in 4 chapters: scan, plan, make, done. Scan means acquiring all the digital data in any ways possible, which gives us the is situation of the patient on a digital platform, in a digital format. That means we take digital photographies, videos. I think that I have to, we will see that we will have some voices. That was my orthodontist which treated this case. Oh, I didn't notice that I have to mute all these videos, but nevertheless, you will hear my voice. So videos, photos in a different perspectives depending of which digital smile design or visualization, digital visualization of your future smile you will need. Another technology is the cone beam CT technology, which is the base of the planning of the implants in the bone, of measuring the bone and the soft tissue quality, of matching it with the STL files of the future smile. And what is important about these cone beam CTs? It is important to have a high image accuracy. So in order to be able to choose the right technology, you have to take care of some parameters like multiple fields of view, low dose. In the future, we will work with 3D pictures, not 2D anymore. And it's normal because we plan to 3D, we plan and we work 3D, so we cannot really make a diagnosis 2D. It's poor. So the patient positioning should be good. Then the artifact reduction, and here are many artificial intelligence software which are helping us to go there. And also to be able to have more information in the same technologies. Very many technologies are superimposing the cone beam CT with a face scan. Then we need digital data of the teeth of the patient, that is situation, which can be done with an intraoral scanner or even with a desktop scanner indirectly. Now, we are searching also in this digital society the trueness, precision, and accuracy of all these devices. And of course, we choose the one which has the highest accuracy of the technology. Now, the studies on those technologies are showing, and there are different studies on all those. Every day is a new scanner coming out, and we implement those in our studies. Now, all of them are quite accurate and reliable in single or couple of teeth restorations, but in full arch restorations is still not the accuracy that we would like to have. That is why I will have to, okay. Nevertheless, we have also softwares which are registering the function, the movements of the jaw. And like in the video that you saw before, I don't want to annoy you with the music. That's why. So we can register not only the scan, but also the movement of the jaw, which we upload in our softwares of planning and of working digitally. So this situation, including the implementation of the occlusal vertical dimension, it will be able to be done by this technology. Of course, the digital registration and control of the occlusion, which is sensor-based today, is very important, and I will go into that later on, because we know exactly how important it is in the prophylaxis of peri-implantitis, which is infection plus bone loss, to have a perfect occlusion, right? So we visualize now the facial thirds on the hand of the photos, and we judge the occlusal vertical dimension, and we increase it if it's necessary. So then we go to the golden proportions of the teeth, and you have outside so many nice softwares which are enabling the golden proportion of the teeth, and this is the final visualization of the 2D Just a second. I have to interrupt this because this is so annoying. Well, we will have to go over that. Okay. So, in the plan, that was all scanning. That means encountering and acquiring all the digital data and visualization through different softwares, which have 2D possibilities, but also 3D possibilities. Some of them are, as you can see here, also implemented in the ExoCAD plan in some of the planning softwares. Plan means the planning of the smile. So from the 2D dimension, you go to 3D planning, and you also plan the guide. in a 3D manner. You plan also by after matching of the cone beam CT with the STL files. This is the basis of the planning of the implant, of the bone, and of the future construction. And also, we plan the provisional in advance. So this is the plan section. Then is the make section. So on the hand of all this planning, we materialize the provisional, the guide, and also the models through milling and printing procedure. The printing procedure is the future milling. Printing is very promising, and I will talk at the end of the lecture more about new printing technologies. And of course, all the surgeries are today digitally done. All the cases which, since we know how to plan the implants and we know that the precision is higher than in the freehand surgery, that means that all the cases in the last years is today no case that I don't do without a digital planning. So of course, all the workflows has a certain accuracy which has to be controlled and has to be validated, and this is our mission in the Digital Dentistry Society, and that is why we do a lot of studies concerning the accuracies in computer-guided surgery. For example, we have this young lady which is missing the frontal tooth, is missing a volume, more of the bone, more of the soft tissue as of the bone. Therefore, we do a soft tissue management with a connective tissue, which is implementing our soft tissue situation. And then we think about an implant design, which is giving us a good initial stability in this bony situation. Implants generally have to have this feature today. A thread design, which gives a good initial stability, a platform switching design with all the advantages that you know. I don't go into details because our time is quite limited and we want to go through all the details. Conical connection, which is proven through studies to be the most stable connection on implant between abutment and implant, and the concave emergence profile with some advantages which you will see later on. So we use and we choose from the market, from the 3,500 systems which are out there, the ones which is giving us the advantages of primary stability, the advantage of conserving the bone around the implant, and the advantage of an aesthetic environment around the implant by keeping the bone and by giving us a right volume or maintaining the volume of the soft tissue around the implants. The dimensions or the placement of the implant is very important. We don't really go into details because you're for sure all very skilled and very experienced, but a precise positioning of the implant is guaranteeing already quite of a good positioning or good aesthetic result. That is why an previous planning and an digital planning and inserting fully guided of the implant in the alveolar is the way to go and is offering the highest precision. Every discrepancy of 0.5 millimeter will give you compromises in the result. That is why also in this case we use a guided surgery to place an implant in that position. Uli is doing that guide, and the implant axis has also a high importance in the outcome of the crown, even if we don't think so. First thing is also the decision and the possibility to do it screw retained or cemented. And in the previous years, we thought that if we are not able to place that screw palatally, we are wrong. But the study of Joseph Kahn shows us that in 80% of the situation, you have an anatomical compromise situation where all the screws are coming buccally in 80% of the situations. So we have to use either a tilted canal or an multi-unit abutment for a single tooth or any other component in order to make an screw retained attachment palatally. Otherwise, we still have to cement, and the criterias where we can cement without compromising the bone or without creating the conditions for a peri-implantitis, we will talk about in a little while. So by the connective tissue, which we did, we gained that volume of the soft tissue which we needed, and we will talk about those parameters in a very little while. And through the concave profile of the running room, we create and we maintained this color, this nice soft tissue height, which we also add thickness, which we need for a stable bony and soft tissue situation on the long run. We knew always that we need 2 millimeters of bone around implant and 3 millimeters soft tissue if it's possible. Nevertheless, we realized today, and I will show you later on which are the new parameters, that the addition of the volume of the bone and the soft tissue is for the aesthetic the most decisive. Nevertheless, Joseph Kahn is still gives us this parameter to graft the bone inside the socket in the left side or outside the socket by opening the flap in order to have a bone of 2 millimeters. Yeah, so that doesn't mean in the digital surgery, digital plan surgery, that we sometimes don't have to open the flap. Depending on the defect, depending on the situation that we have there, sometimes we have to open the flap in order to gain our soft tissue and bony situation, which we need to have. Generally, we say we need 3 millimeters of soft tissue thickness, 3 millimeters of tissue height, and 3 millimeter attached gingiva around implants, and this is a take-home message, in order to have a stable environment around implants. Now we get a step forward because there are new parameters which we see in our studies, in our clinical works, in our retrospective studies, and also in the prospective ones. The design of the abutment is the one you can see. You have a concave profile of the running room, that S-shaped form of the abutment, which is assuring to the concave profile and conservation of the structures, and the convex part, which is definitely in the connection with the soft tissue, is convex, is used for designing, or let's say managing the tissue between tooth and implant versus between two adjacent implants. So the implants with S-shaped concavity are definitely give a firmer connective tissue barrier, a better soft tissue regeneration. So that means that if on the left side we have implants with platform switching design, with a thickening of the soft tissue, a thick soft tissue biotype, or increased soft tissue, a platform switching design in order not to lose the bone, we have already much more supracrestal fibers which we can use for our designing the papilla. And if you look in the right side, the design of the final abutment in an S-shaped concavity will implement, or will even improve even more, the dimension of the papilla between two crowns if the distance to the contact point is appropriate. So those are dimensions and the possibilities parameters to create the soft tissue between two implants, but also between an implant and the tooth. So back to the design of our implant, of our patient. This is, in conclusion, the situation that we can have on adjacent tooth and implant, which rather cannot see the difference. And that is why the patient is satisfied on the long run and on the long term. Now, she's sending photos always about her, success in life, and it's really nice to see that. that stable situation on time. Now, nevertheless, the stable situation has to be measured and has to be documented. And that is another example of another big case, which I don't have very many. I have more big cases, which I will have probably to go faster through. This is a missing lateral case where my orthodontist treated orthodontically in order to open the gap for laterals as implants. So we all know that when we have that situation, we lack bone in the lateral zone. So we have to graft first the bone there in order to be able to place implants if we don't want to go for Maryland bridges or other situations. So in order to see what we need and how many teeth we need to do with a minimally invasive preparation to have a pleasing smile, because you saw that the patient had quite a gummy smile. Nevertheless, she didn't want to go to full arch reconstructions. We made minimally invasive procedures in the frontal area. We still needed to graft the bone at the beginning. So those that incision has to be done also minimally invasive and in a way that doesn't leave scars. So we have to choose from the incision line also the one which gives the less problems and the less complications aesthetically seen, because this patient has a gummy smile, which I cannot really correct completely. So we have the option between an intrasulcular incision on the left side, which gives a recession, most in the 80% of the cases, or on the right side, an papilla sparing incision, where you can see the scar after 1 year in 77% of the cases. So what do you prefer? So we prefer a hybrid solution, which is in the middle. We take an intrasulcular incision and an curve in order to conserve at the same time the papilla. So it's a mixture between the two incisions in order afterwards not to have the scars. So that is the result after the grafting. Of course, today we can go for lateral grafting with minimally invasive procedures like the SMART technique, which we started to use shortly. And this is a kind of tunneling or a pinhole technique for the soft tissue, but which we use in a full thickness flap in order to graft also the bone. So we have a tunneling for bone grafting also, where we can introduce the bone or only the soft tissue. And we have that kinds of results where you see the old bone and the new bone. And actually, this is the situation which we have in the young girl's case. Yes. I can hear a microphone.
It seems that everything is fine.
Yeah, more or less. I mean, my videos are not muted, so that is why it's so difficult to. But I will manage, Elena. Okay. So you see the bone and the soft tissue. The green line is the soft tissue and the bony situation and the position of the implant. So we realized that by the digital planning of the implants, where first we did an digital walks-up, a 3D digital walks-up, and planned the implant based on the aesthetics, we see that we need to have a certain position of the implant in order to be in the new created bone. And we make an digitally placed, perfect placing of the implant, let's say, yeah? It's much more perfect than, much more exact than the freehand. And you have then, you realize you have in the retrospective study that you have a stable situation when your planning is respecting 4 millimeters of implant depth, of the implant, which can be 3 millimeters soft tissue, 1 millimeter bone, or 2 + 2. So the total distance, the total dimension of the soft tissue and of the bone should be 4. This is a supposition which is confirmed by many postoperative long-term cases, which is part of the statistic which will be published in a short while. So first is the new parameters of the depth of the insertion. Another parameter which we saw that is needed to be respected is more than 4 millimeter, the same number of 4, which is the soft tissue thickness, so the green line, and the bone thickness until the crestal margin of the implant. So that dimension with the noted by the red arrows together should be 4 plus, and then that volume will be maintained. So checking all these dimensions, this is the situation after the uncovery, and then CAD/CAM preparation, CAD/CAM fabrication of the veneers which we did, and the crowns over the implants. And we have here, after 2 years, the pink aesthetic score and the measurements of the volume also in this case of the patient. And we see that if this dimension is respected, we don't have a volume loss. Even if the bone, the bone and the soft tissue together were more than 4 millimeters. And this dimension was proven and controlled in many cases afterwards. So this number should be respected in the digital planning, which we certainly cannot respect with very high predictability in a freehand placement. That is why the digital planning of the implant and the navigated surgery is much more controlled, it's much more precise and much more predictable, aesthetically seen, and from other parameters too. So this is the patient. Okay. Now, what do we do in full arch navigation? How does that work? Now, the workflow is the same, and I will really have to hurry up. We have all the 4 steps. I mean, scan, plan, work done. We have in the full arch reconstructions always to respect the long-term stability and guarantee of the situation that we want to create. I always do a treatment which I can give the patient a guarantee that he will have no problems, no big problems between 15 and 20 years. That means that all the teeth which have not a prognosis of more than 5 years will be not included in the construction. I mean, whatever we do on those teeth, veneers, crowns, or nothing. If after 10 years that tooth can be replaced with a single implant and the rest of the construction and of the concept of the smile of the patient will be still there, then I go with that plan. So I hope that everyone understood is not so easy to discuss with people which are not looking into my eyes, but nevertheless, I hope that this message is going through, that we need to find solutions of prophylactically, planning-wise, and working-wise in order to give this patient a long-term guarantee. And also criteria and decision trees with periodontal compromise situation, which are the most of the full arch cases, and implant treatment. So consensus is that when the tooth or the teeth which have a remaining infection after 1 year of treatment and the residual bone height is less than 8 millimeters, then we should opt for an implant, because otherwise we need much more invasive and much more unpredictable treatments in order to give this patient a decent result. So we need an aesthetic success and also a stability success on the long run. So by aesthetic success, again, we need to set and to respect parameters, and a couple of them I showed you in those small cases. But actually we need also, as in the traditional implant dentistry, parameters to an algorithm for a digital plan and a digital workflow on implants. So the aesthetic planning is starting with a planning of the fixed prosthesis, 1, 2, or 3. We don't go into detail. The FP1 is the fixed prosthesis which doesn't need any raising the flap. And I will go very fast through a couple of big cases. Some of them are more recent, some of them are older, just to mention some of the particularities which are coming in the digital workflow, and then we will treat one case really thoroughly, because in order for you to see that every situation is individual, that in every situation you have to think through all the case and then go for the mentally finished case. In the surgery, you have the case actually finished in your head. So this is a lady which comes in a disastrous situation. As I mentioned, the planning can be done today already in the planning software. So I mean the planning of the smile, all the planning softwares have already a planning software inside, a smile design and so on, where we can introduce and implement the Mojo Registration, which is a movement, the registration of the movement. And this is so precious, and this helps me to get rid of the FacePo, of the bite registration, and I can increase the occlusal vertical dimension already in this registration and take it with me through all the workflow until the end of the treatment. So those are upper, lower. We can also do the face scan sometimes with the same technology, and we implement all this digital data in the same phase, right? Then we go for the planning, upper, lower, tooth by tooth. Then we go to the make situation. Make, that means we fabricate the guide. Always guides which are supported by teeth, additionally to pins or without pins. We know from studies that the tooth-supported guide is much more predictable and precise than a soft tissue supported guide. So it makes no sense to extract a tooth, place a guide with pins, because the actual teeth, the 2-3 teeth which we maintain, are giving us a much more precision of the work. So we fabricate and we manufacture also the provisional in advance. We use different techniques in order to maintain and to reproduce the occlusal situation. I mean the occlusal position in that toothless situation. And then we go for the surgery, right? So of course, we don't go deeply into the surgery. We always do a full guided surgery, and we respect in that surgery that the placement of the implant in the depth, considering also the soft tissue thickness and height, and act accordingly. Where we don't have the soft tissue height and thickness, we do additional methods, which I will show you later on, with PRF, with connective tissue, with matrices which are able to implement the soft tissue thickness in a non-invasive or more invasive methods. Nevertheless, the patient goes with this provisional home. Yeah, so it is a difference how she came and how she goes home. Another case is also a recent case, which we did together with Alpha Bio too. This lady comes with this disastrous frontal situation. She doesn't really, well, she strives to the reconstruction in the frontal area. Of course, it will be treated first. This is the Mojo registration, the functional registration of the movement in our office of this patient, as you can see. And this movement will be transposed in the WOX app, and later on it will be kept for the final reconstructions. Now, first we plan the provisional, we match the best way, the face scan and the cone beam CT, we implement the movement, and by matching the STL files with the cone beam CT is giving us the fuel for placing the implant in the right position with certain distances to the nerve and to the important anatomical structures. Okay, we go a little bit faster. Maybe I will go over the time a little bit if Elina will allow me. Materializing our planning is giving us the model, the models, the guides, and also the provisionals, as you can see. So we go for the surgery where we place this provisional in an immediate loading procedure, since the Alpha Bio implants are really have an extremely good primer stability. That's why is the middle of choice. And this is how the patient is looking immediately after the surgery. This is an old case of a lady which needs fixed teeth on the upper jaw. We make the same way. We work with two guides, one on the residual teeth, and after the extraction of the residual teeth, we use the second guide. The soft tissue is thin. So in this case, what do we do? What is special about this case? We implement the soft tissue quality by placing matrices which are able to implement the soft tissue thickness in the height and also in the coronal place, like mucograft, mucoderm, PRF, depending of how much thickness do you still need to achieve. And I will show you later on. This is the provisional, and here we go for the final reconstruction, and those are tooth by tooth reconstructions and the happy patient at the end. Okay. Now, since we don't have very much time, I will jump a little bit over, let's see, this case. This is also an case which we did in one of our courses, and a live surgery with Alpha Bio is Mrs. Goy. She's coming with a denture. Looks really disastrous. She is also an anxious patient. And also from those situations, when we have still natural teeth, we can give this patient an FP1 construction. So that means even if the patient comes with a partially edentulous situation, we can strive to an FP1 fixed teeth situation, which we did in this case too. So this is the initial situation, digital walks up, planning of the implant, of the Alpha Bio implants in that dimensions, which I mentioned before. Always keep the 4 millimeters depth and thickness. In this case, because the patient didn't have any teeth in the upper jaw, we had to fix it with 3 pins, which is very many times the case. But as I said, if I have 1, 2 teeth, I try to maintain them. Okay. So it's planning of the guide, planning of the implants, planning of the pins. We get then, this times with 3 shapes. So as you see, we work with many softwares. The Alpha Bio is implemented in very many software systems of planning. So you don't have, you are free to use every system. You have also in this system the possibility to see the primary stability, the good primary stability of the implants, the bone density. So we plan the guide, and then we make the model and the guide with a printer. Statistics are showing that the better the quality of the printer, the better the quality and the precision of the guide and also of the model. So we print those kind of models where we do the provisional in advance, and you can see that we have no pin component in this situation. Nevertheless, we always see in the provisional how the patient will look like, and small adjustments are always possible and maybe necessary to do. Is not a problem again to increase the occlusal vertical dimension sometimes in the Mojo already, and reproduce or give for the final result, for the final reconstruction, the higher occlusal vertical dimension. So this is the guide, the way we planned. In the lower jaw, as I mentioned, we work also with 2 guides. One will be placed on the residual teeth in order to give the first stability. Then we mount the guide on the existing, on the placed implants with the mountings, and then we place the other teeth on the place on the extracted teeth. So might sound complicated, but for the sake of the precision and of the higher precision, we act like that. It's much higher the precision than extracting all teeth and placing 3 pins. So this is all the things that we get for the time and for the moment of the surgery. We use the guided tray of the set of the implant, which is very easy to use, is self-explaining. I don't go into details. And we get also a list of the implants and of the height of the multi-unit abutments in order to do this immediate loading of the patient. So we did that, and as usual, we can do through the guide also an internal sinus elevation. The patient had a little blue, was a little blue afterwards, but she was okay. So you see that seems to be needed and higher, because in the lower jaw she had a denture and she lost bone volume in the lower. We needed to do a PIN component in the lower, and of course, and when we see the provision and we see that the OVD is decreased, we increase that, but we have the possibility to increase it without any problems. And this is the final result of the patient, and she's quite happy now. Best regards from her. Now, when we go into this was a case which I learned at the beginning a lot out of it, and that's why I give you my conclusions concerning this, some algorithms based on this case, and then I will show you the future a little bit. I will go a little bit over the time, yeah, but you will excuse me. So this case is an 32 years old cosmetician, which is very unhappy, even if she doesn't look like, with this situation of the teeth. 1 year of treatment, we decide to extract. We don't go into details. We extract the upper teeth. We have no chance to keep this mobile teeth. In the lower jaw, we treat 7 teeth periodontally and we maintain them. We do, and at that time we did an normal walks-up, which we scanned in the lab. We show to the patient what she gets. She will get single teeth in the frontal area, bridges in the lateral zone, and in the lower jaw we maintain 7 teeth, and you can see here, and the rest of the teeth will be replaced with implants. Matching the STL files with the cone beam CT, it gives us the perfect visualization of our future surgery. We plan in this case which teeth will maintain for supporting the guide, which will be the second premolars, which we extract at the end, because since we do bridges, right? We see the position and we place the position of the implants after the parameters which we set before, 4 millimeters. And we also think how we go through the surgery mentally when we do the open sinus elevation this time. Because in some places there's no way to do it close, so we plan all mentally, yeah. So all these parameters, all these algorithms, we have to plan in together with your planner, and we take the responsibility about what we plan and about the result that we get. So that is why we decide if we go flap or flapless. We decide we graft inside the socket, or we have to open the flap to make it outside the socket. If we have inside the socket, we know that if we don't take care of some parameters of bone and soft tissue, we will have a resorption. So don't go, since we don't have the time to all these studies, but what we know is that we need that volume of the soft tissue and bone around the implants, independent on the implant system. So we need that soft tissue thickness of 3 millimeters if the bone is thin, which is very much the case in the buccal plate. 90% of the buccal plate is less than 1 millimeters. So that is why in those situations we have to implement the soft tissue, and this is a rule since a long time. Thin tissue biotype will be grafted. So Linkevicius told us that even if the implants have a platform switching design, if you don't thicken this tissue, we will have bone loss if the tissue is thin. So in all these conclusions of the tissue thickness and height leads us to that parameters which I told you before of insertion of the implant by 4 millimeter, 3 millimeter of soft tissue ideally, and 1 millimeter of bone. And also this tissue will be keratinized, because if we don't be keratinized, it won't have that height. So we need that keratinized gingiva around implants, okay? What happens? So those are the parameters which we need to create on the long run in order to have that stability, which I showed you in the cases before, and only these parameters will give you the stability. So in the non-flap situation, we use tunneling, envelope, pinhole, smart technique to increase the bone and the soft tissue thickness depending on what we need. If we have a flap situation, or when we need to graft even more, then in the same session, we measure the thickness of the tissue, and we use in the same session an grafting and an implementing of the soft tissue thickness with matrices or matrices plus PRF. And this is a result of a study over 2 matrices plus PRF and the histological results, which shows us that in implementing the matrices PRF into as methods to increase the soft tissue thickness will give us very good results, or the parameters that we need, and we can quantify those parameters, seeing that some matrices are giving us an implementation of the soft tissue of almost 2 millimeters additionally. So this is the tendency to quantify the soft tissue grafting. So back to Asamine, the depth of the insertion should be 4 millimeters, whereas ideally 3 millimeter soft tissue height and 1 millimeter insertion under the bone level. So this is actually the algorithm which we need also in this lady's case. The provisional will be made in advance, and we go to the surgery flapless, as we said before. And we have this aspect of the implants, and you can see that the precision of the insertion is much higher with through the guide as with free hand. It's not as precise as you think. It has a discrepancy of 0.75 at the collar and 0.8 at the apex of the implant, but still is much more precise also concerning the axis and the predictability of the construction by guided surgery. Soft tissue thickness is there. We place the provisional, and that is the patient, the happy patient, which is occlusal situation will be checked by sensors, since it is an immediate placement, immediate loading, and a balance, and we need a balanced occlusion. Now, we know that the intraoral scanners are not precise enough in full arch reconstructions. Of course, there are tendencies here and there, but statistics are showing that we're still having a better choice when we do an normal and real impression over the multi-unit abutments, and we do an impression over the provisional. Matching these two this will be the place and the fuel for doing and modeling the final abutments, which has to have an S-shaped form and has to have the margins of the abutments paragingivally or slightly subgingivally, especially when we cement some of them, in order not to have the cement in that sulcus or in the neighbor row of the bone. I hope that this is understandable. So there are softwares which are able to calculate the margin of the abutment or the level of the margin by the thickness of the tissue and give us immediately the result. So those are the shapes of the abutments in this case, and you can see that the margin is paragingival. What is also important is the distance between the margins of the abutments. The distance between the implants is clear and it's pre-planned. Now also here the technician has to speak the same language with the planner and with the clinician, because otherwise the situation will compromise. If the distance between the abutments is not 3-4 millimeters, we will not have the place for the papilla, enough for the base of the papilla. This is the situation of the Asamoah. This is her name. That is the result of the abutments, the result after 2 years. So the situation before and the situation after, and also long term, because this is one of the one of the cases in the retrospective study. And this is the situation after a certain time, respecting the parameters, we don't lose volume. And also a recall of every 4 months and a decontamination of the peri-implantary regions with a method of your choice will be the best prophylaxis for a long-term maintenance. We avoid infection and bone loss, right? So there is this sensor-based device which I recommend to you to have a 25 microns precision of the occlusion. Okay, so I will also will show you some. Let's see, I will jump a little bit because Elina will give me maybe 5 minutes more.
That's fine, we can continue.
Okay, thank you so much. Okay, so there are guides, since there are a lot of, let's say, rumors about the sleeves, about not being able to sterilize the guides. So we have other types of guides, this is an innovation from Belgium. This guide is guiding the implant not by sleeves, but by the handpiece, as you can see here. It looks a little bit strange, but it has a lot of advantages by having a good visibility and a good irrigation, possibility of sterilization and so on, and is compatible with the normal tray of the system. You don't need a separate guided tray, which is a big advantage, I mean, for everybody. So seems to have a higher precision. Today is made by resin. You can print it yourself. So seems to have a higher precision. We did a lot of cases this time. Now this time the sound is good. I don't know what happened before that. Okay. This is one of the cases made with this system. Okay. Soft tissue situation, final situation, and the final and the happy patient. Another guiding system is a dynamic navigation. The dynamic navigation gives us the possibility, this is our surgery, they give us the possibility to work freehand, but guided by a target here in the middle. Okay, I will go further on because it's very noisy. And we did also full arch cases with this system. Has also advantages, is not as precise as the static guide, but it's much more precise than the free-handed. And it is also a way to go. You don't need time to fabricate the guide. So after quite a learning curve, then you are able to use the system immediately because the planning, you can do the planning immediately and go for the surgery. Okay. So this is the final situation. Okay. So independent of the system, static and dynamic navigation needs a learning curve. And that is why we need also education for not only for the doctor, but also for the entire team. Now, again, this is the result of the retrospective study over those full arch cases. And as a conclusion, we have kind of parameters which we know, couple of parameters which we know, but a lot which we don't know, and a lot of necessity of accuracy, trueness, and precision of the devices, and also their integration in a coherent workflow without having discrepancy and losses in the precision or accuracy. So I mentioned a couple of parameters. I don't go into them again. You can make a photo of this, and the presentation is registered anyway, so you can go back to this to this slide and go into depth. Now, of course, there are 2-3 things which are coming and which we are all excited about, and where we are starting to do, and not starting, we're in the middle of some research, is artificial intelligence in planning in very many aspects, from the diagnosis until the finalizing of the work. Printing is the next milling. Printing ceramic is very exciting by one of the companies, for example, which are able to print ceramic crowns with a thickness of 100 microns. Imagine that, guided, minimally invasive preparation. By the way, another minimally invasive preparation is by First Fit. Very nice systems which are coming. And all these methods and all these technologies makes our job so exciting, and the more predictable, the less the frustration, and the more the satisfaction of every member of our team, but also of our patient. And this is actually the fruit, the reward, the applause of our job, of our daily job. Now, I thank very much Alpha Bio for this opportunity. And concerning digital data, digital informations, I invite you also to join the Digital Dentistry Society, where I am a part of, as a free member or as an active member, just by registering this barcode or going onto the website. I hope this Alpha Bio will be with us in the future too. Very exciting program of the Digital Dentistry Society in cooperation with Goethe University is the Master of Aesthetic Dentistry, going on already and starting a new group in the fall. I will let Elina and leave your data on a Facebook, your Facebook group of Alpha Bio. So if you have interest, feel free to look at my presentation again, and I am very happy to answer all your questions which you have, and thank you very much for your kind attention all over this globe. Thank you so much.
Thank you very much, Dr. Lerner, for with